All right, if you would take your seats, please. We're ready for the last presentation of the afternoon. So while you're taking your seats, just a couple of items of business. There will be a reception afterwards outdoors, and there are surveys on your tables asking you about our conference today and what you thought, opinions about the various talks and things. So if you could fill those in and hand them to one of our staff as you're leaving, we would greatly appreciate your feedback. So here we are at the last presentation of the day, and we're delighted to have Jim Rebitzer come talk with us from Boston University and the NBER. So Jim, for, I guess, sort of the initial part of his career was known very much as a labor economist and not doing any work in health. And he became, sort of a terrific expert on all aspects of labor economics and incentives. And I don't know, I never heard the personal story from you, Jim, but sort of somewhere along the way, maybe a health economist got a hold of you. And he ends up publishing a paper, collaborating with these health economists, talking about physician payment incentives in health maintenance organizations, and it's a terrific paper. It's more than 10 years old, but I still teach it in my class to my graduate students because it is so fascinating. And he was looking at physician incentives and payment incentives before anything started clicking in the general health policy world about pay for performance in these various sort of accountable care organizations, which he's talking about today, and has continued to publish on and do really terrific work, insightful work in the area of health economics. So you wouldn't know this, but he received the Best Paper Award in 2011, the Ken Arrow Award, Best Paper in Health Economics, looking at search frictions for health insurance markets and talking how important that was. And one of the things I don't think the policy people sort of picked up on, and I think I've got the policy implications correct, is it's sort of arguing that these markets will function much better if you actually have a public alternative in them. And sort of that seems to be an aside. It's like, oh wow, this is a very important study. And so I encourage you to sort of look that up. It's kind of you may not want to sort of crunch through all the models and the equations, but sort of the various different ways in terms of how the policy works is a very useful lesson. So with that, I'm going to hand it over to Jim, and he's going to tell us about ACOs from a labor economist perspective.
Thank you. You all can hear me, right? Great. Good. It's always tricky because the last speaker after lunch, after a break, and the person between you guys and the reception. So I'll try to be very clear and very efficient and get you to the reception as cleanly as possible. I began my career teaching at the University of Texas in Austin, Texas for 3 years. That was my first job. And I've always been grateful to the people of the state of Texas for giving me an opportunity to learn my trade. So I'm very happy to be back here, and thank you for inviting me, Vivian. So what I'm going to be talking about today is the part of the healthcare reform that's been alluded to lots of times throughout the day, but we haven't had a lot of time and effort to it, which is what's happening on the incentive side, what's happening on the healthcare delivery side. And I'm doing it by talking about incentives in accountable care organizations. Let's see if this works. So what I'm going to be doing is presenting to you an economic analysis of what happens on the insides of accountable care organizations. And the fact is, we don't know a lot about that. As economists, as managers, as health services researchers, we don't know a lot about what happens on the inside. So you're also going to get a chance to see what economists do when they don't know a lot. So that's what I'll be showing you a little bit about how that happens. So there are going to be a number of points I'm going to make in today's talk. The first is that inefficiently fragmented care delivery is potentially a very big drag on the healthcare system. And I'm going to make the point that ACOs are a brilliant policy response to this fragmentation, provided, of course, that they work. And what I'm going to do is raise questions to you about how they might work or ways in which they might not work that are going to touch on some of the issues that Jay raised in his talk earlier about these are wonderful ideas, why haven't they evolved and taken over the world before now? Why is it that we need to promote through public policy an organizational form that could easily have evolved on its own? And I'm going to have some suggestions of an answer for that, though not by no means a definitive answer. And then I'm going to talk a little bit about the economics of ACOs themselves. And I'm going to try to make the point for you that ACOs are best understood as an experiment in pay-for-performance incentives. P for P is shorthand for pay-for-performance incentives. And I'm going to make the point based on simulations and calibrations, which is not the same as exactly made-up data, but it's not based on real data. But I'm going to make the point that it's very likely that the pay-for-performance incentives in ACOs are not self-financing. I'll tell you what that means. And so likely, most of these organizations will be operating with underpowered incentives. The incentives which are built into these organizations will not be sufficiently powerful to do the job they're intended to do. And then the question is, how can they operate? How can they succeed? And can organizations function with underpowered incentives? And the answer is yes, they can. But making ACOs work will require complementary incentives in addition to or that strengthen the underpowered pay-for-performance incentives. And the sticking point, and I'm going to tell you a little bit what that means and how real-world organizations cope with this problem. And then the sticking point is it's not clear yet that these complementary incentives, these additional incentives that are required to make the ACO model work, that those things could be implemented where the ACOs are most needed. So those are the points I'm going to make today. Hopefully by the end, you'll see why I make these claims. And if you don't. All right, so let's start with the basic economics of the healthcare system. If you draw a little diagram, and then the vertical axis is quality here, and this is affordability. And you think that's the U.S. That's the frontier. These are the best mixes of affordability and quality that are achievable in the system, given the current state of technology and what we know. The U.S. healthcare system is there, that's a very precise dot, and there we are. And the question is, why are we there? Why are we so far from the envelope, so far from what we could be doing best in terms of affordability and quality? And I'm going to organize this talk around a particular hypothesis. It's one of many explanations for why we're so far from the frontier, and I call it the fragmentation hypothesis. Fragmented care delivery, for a very fragmented care delivery system, is an important cause of inefficiency. So here's how this is how I state the fragmentation hypothesis. First, when care delivery is spread across large numbers of distinct providers, poor coordination leads to high costs and low quality. Secondly, the inefficiencies due to fragmentation are worse when care is spread across providers working as independent owners of small practices. Onesies, twosies, threesies, foursies docs dividing care amongst themselves is a real recipe for making fragmentation a problem. Fourth, the inefficiencies are especially severe for patients with serious chronic diseases. So that's the fragmentation hypothesis. The fragmentation hypothesis is not only a widely discussed and widely believed, though very poorly documented, explanation for why the U.S. healthcare system is underperforming. It's also a primary rationale for the introduction of accountable care organizations into the Affordable Care Act or Obamacare, whatever label you particularly prefer. ACOs were considered to be a response, a fix to the problem of fragmentation. I'll come back to that in just a little bit. So first question I want you to consider is, does the fragmentation hypothesis make sense? And the takeaway that I want you to take away from is it has a surface plausibility, even though it has not yet been there's a great deal of work to be done to establish its importance. So, the first observation is truly integrated healthcare organizations are islands in a sea of fragmentation. You have the Cleveland Clinic, you have the Mayo Clinic, you have MD Anderson, you have, Kaiser. But for the most part, docs aren't delivering care that way. In 2001, which is the year that I had comprehensive data for, 60% of docs worked in solo practices or in groups of 2 to 4. Lauren Baker, only 7% worked in groups with more than 50 physicians. Lauren Baker, who's done some more recent work on this, still finds that the modal size of practices is around 2, 4, I don't know. But we're not talking about large integrated entities here. We're talking about highly motivated, highly entrepreneurial physicians working in small organizations. So that piece of the fragmentation hypothesis seems to make sense. The second piece of the fragmentation hypothesis, is there any evidence that fragmentation of care delivery actually leads to higher costs and lower quality? And I think the answer to that is yes, though the studies have been, in my opinion, quite limited. Here's a study, here's a study, some results from a study that I've done with Ashish Jha and Brigham Franzen and Karen Joint. It's unpublished, and so I'm going to go through its details only very sketchily. We don't have time, and also I want to save it for the journal. But basically, the journal that we'll be lucky enough to publish it one day. Anyways, we had data on 1 million chronically ill patients from a big commercial insurance company. We constructed an index of how fragmented, we divided their care for similarly patients into fragmentation quartiles. That's this axis. And here, on the vertical axis, are different dimensions of cost and quality. So this is, these are regression-adjusted cost and quality outcomes, and this is per patient costs. And if you look at the second to the third quartile, you see big jumps in per patient costs. This is controlling for all kinds of things that we can measure about the disease state of the patients. It's imperfect, but it's suggestive at least. You see the same thing here with the probability that somebody is going to be hospitalized for ambulatory care sensitive diseases that could be, hospitalizations that could be in principle eliminated by proper outpatient care. You see the same thing. These are sort of complicated and sophisticated measures of care, of gaps in care, potential errors that physicians have made. And you can see, again, this big jump from the second to the third and then to the fourth quartile. So based on this data, at least, again, there looks to be an association between the fragmentation of care and its cost and quality. Fragmentation does not look like it's good for cost or quality of care. Whether these relationships are causal or not, I leave that to you and to the referees to hammer out. So this raises a question that Jay raised, and I think is a first-order economic and policy question that has been given almost no attention, almost no serious attention. I think there should be a lot of work on it. If fragmentation is inefficient, why does it persist? Usually we think in competitive environments that inefficient organizational forms get competed out by efficient organizational forms. Is there something that's broken in the market for organizational form that leads to persistent inefficiencies, that U.S. healthcare system could get stuck in this apparently fragmented place, even if the efficiencies are substantial? And so here's my story, it's only my story. Again, there's no proof for it, and I haven't even written it down in a formal model, which would be a first way of testing it. But I think it's plausible, and I'd like you all to nod in agreement. No, I'd be very interested to talk about whether it's plausible to you. But the first order explanation is that payers don't reward cost efficiency or quality, therefore cost inefficient organizations can persist. The question is why? Why would that be? Why would that persist in an environment where there'd be a big competitive advantage to payers who did reward cost and quality? And there are two pieces to my story. One involves institutional rigidities, and the other involves a coordination failure. The institutional rigidities involve Medicare, and they were already mentioned today by the gentleman who spoke, I'm now blanking on his name, the CEO of MD Anderson, John Mendelsohn, right, having to do with Medicare. Medicare can't, and Fiona mentioned the same thing in her talk, that Medicare pays every physician for services that they think that are necessary, regardless of their efficiency or efficacy. So it's locked, Medicare is locked into fee-for-service payments. and it can selectively contract with efficient docs. So Medicare is prohibited from doing all the sorts of things that might introduce cost efficiency into the system through payments. The question is, what about the private sector? Why doesn't the private sector move? 60% of the payments come not from Medicare, but from the private sector. Why don't they do that? Why don't they introduce payment systems that reward cost, efficiency, and quality? The answer that I like, that I did not invent, has to do with coordination failures. This is a sort of a game theoretic idea. Private payers might want to offer global budgets that reward efficiency, but they can't find providers who can implement these payment systems, who could live with them, who know how to manage them. These are difficult and tricky things to manage. In an environment where the big payer, Medicare, doesn't demand this sort of stuff, and the private payers aren't demanding it, providers don't invest in the infrastructure to implement it. Well, if providers don't invest in infrastructure to implement it, it doesn't make sense for payers to start demanding it. And you end up with without local payers, providers don't make investments to implement these payment systems, so you end up stuck, right, where you might be better off if both providers made investments and payers made investments in these new payment systems, but neither will do it unless it's sure that its counterparty will also do it. And this is sort of a classic game theoretic dilemma that allows you to be stuck, even for very long periods of time, in an inefficient equilibrium when there's an efficient equilibrium just outside your reach. The way to get out of a payment, the way to get out of a coordination failure is to have an outside force kickstart it. Move one part of the system to the new strategy, in this case, the global budgets and pay for performance, and then the rest will follow. And from this perspective, ACOs are extraordinarily clever policy response. A great deal of what I'm going to say today is going to sound critical of ACOs, but that's not my intention. I actually wish I had thought of this idea. This is, I think, from the point of view of a coordination failure, that's your explanation for why you don't get a lot of cost efficiency in the system. It's a brilliant response and a brilliant fix. ACOs break Medicare's institutional rigidities. How do they do that? They allow for a network of providers that can jointly contract with CMS to provide care to a block, 5,000 plus large block of Medicare enrollees. ACOs have global budgets and keep a fraction of savings below those budgets. And to receive these payments, the ACOs must clear stringent quality thresholds. So you can't, at least in principle, get a lot of cost benefit, money from reducing costs by sacrificing on quality. The interesting thing about ACOs is that not only would affect Medicare, but they are designed to jumpstart the private sector's coordination failure. ACOs are expected to sign contracts with private payers, and because they've already built the capacity to handle these kind of contracts for dealing with Medicare, the private payers will find it much more easily start demanding it. So it gets you, at least in principle, gets you out of the coordination failure that leaves you stuck with these inefficient onesies and twosies, highly fragmented care. So it's a brilliant piece of policy, I think. So before we go into how these things might work on the inside, I want to give you a sense of what ACOs actually look like in a world where integrated care is scarce and fragmented care is common. So here's a paper by Elliot Fisher, who's one of the main architects of the ACO policy and has been writing about it very intensively. So here are 4 ACOs that he described in a recent health affairs paper. So one is Health Partners in California. It's an IPA practice association and a medical group. It employed 700 docs with 2,400 affiliated physicians. It has some prior experience with risk-sharing contracts. 94% of contracts revenues are in outcome-based contracts. Here's another one, Norton Healthcare, Kentucky. Integrated delivery system employs all 475 docs, owns 5 hospitals, no prior outcomes-based contracts. Monarch Healthcare in California. It's a loose, independent practice association, 40 employed docs, 2,500 affiliated, prior experience with risk-sharing contracts and outcomes-based contracts. It owns no hospitals, though it's affiliated with 18. Tucson Medical Center, community hospital system, 16 employed physicians, 800 affiliated. It owns 2 hospitals. So most of these are not what we would call truly integrated organizations. They don't employ their docs, they don't own their hospitals, they're not vertically integrated in that sense. And they don't have, we're going to see, that means they're going to not have a lot of incentive levers that are available to truly integrated organizations. Most of these are hybrid organizations. They have a lot of independent contractor docs, and it turns out, and they often don't own their hospitals. And it turns out that this features of their organizational form might matter a lot for the success of ACOs. That the policy requires that these hybrid organizations become successfully integrated, but it may be that the organizational structure poses a barrier. I'm going to give you a sense of what that barrier is in just a few minutes. Okay? All right. So let's talk now a little bit about the insides of ACOs. It's helpful to think about ACOs as an experiment in pay-for-performance incentives. Shared savings create incentives for ACOs to improve efficiency by improving coordination across physicians. But, and here's a question that an organizational economist asked, that I ask myself, how do incentives at the ACO level? Remember, look at these, go back for a minute here, something you should, look at the size of these guys. They have 700 docs, 475 docs, 40 plus 2,500 affiliated docs, 16 employed physicians, 800 affiliated. How does an incentive at the top of healthcare partners translate out to 700 employed docs? How does it, even more problematically, how does an incentive for Norton Healthcare, or for Monarch rather, which has 40 employed docs, how does an incentive at Monarch level translate down to its 2,500 affiliated docs? That's the question that I would like to address now. Here's the way economists model this sort of thing. So how do incentives for ACOs at the ACO level influence what individual physicians actually do? Physicians, and here's the way, this is a story economists tell. Physicians compare the marginal benefits of their actions against their marginal costs. Right? That's what rational actors do. Physicians are irrational. Pause for joke. But this is the way we do the thinking about it. The benefits of improving efficiency come from intrinsic motives. Physicians are intrinsically motivated, and also from the monetary pay-for-performance payouts. Physicians, in the paper that Vivian so kindly mentioned, that I published about HMO incentives, demonstrated. I'm not the first to demonstrate it, many have, that physicians respond with remarkable alacrity to financial incentives, even though they have also lots of powerful intrinsic motivators. So the benefits for improving efficiency come from intrinsic motives and from monetary pay-for-performance payouts. The cost of effort, well, that's an interesting thing when you think about physicians. Delivering medicine requires effort, but it's not coal mining. Right? The cost of effort isn't that, the cost of effort comes primarily not from lifting that shovel, right? The cost of effort comes from what else you could be doing with your time. What else you could be doing with your time that creates value for you, that creates value for your patients, that does something valuable. And it turns out that manipulating the opportunity cost of effort is something that integrated organizations are very good at. And that's going to matter a lot. Hybrid organizations may be very bad at. Anyways, so the cost of effort is the opportunity cost of effort, what docs are not doing when they choose to respond to the incentives. If the marginal benefit of efficient care exceeds the marginal cost, physicians are going to act efficiently. So what the incentive system is going to do is try to raise the marginal benefit of acting efficiently above the marginal cost, and boom, the magic happens. So we're going to now take you on a tour of that magic from the point of view of an economic model of optimal incentive design. So, can ACO level incentives, I got time. Okay, can ACO level incentives actually influence the behavior of physicians? Remember, they have to influence the marginal benefits and the marginal costs of their actions. So what we do is we model, using this marginal benefit, marginal cost logic, we model how physicians working in an ACO respond to organizational level incentives. And knowing these responses, the payer can select incentives to achieve cost and quality goals. And in order to make this model work, we make a ton of assumptions. But the assumptions, which if I showed them to you, you would all think, if you stared at them as long as I did, we're all extraordinarily reasonable. But we make a lot of these assumptions, reasonable or not, to simplify the problem down to 2 parameters that we can measure empirically. And we plug these parameter estimates into our model, and then we ask the model questions. Yes, indeed, it is true that when they are not teaching, economists spend their time asking questions to models, and they expect them to talk back. So we ask the model 2 questions, and these questions, I'm going to show them to you, and you're going to say, what? These are not the first order questions you might want to ask of a model, you might think. But you'll see in a minute that they are actually very important for understanding the viability of ACOs as an organization. The first question is, what is the optimal size of an ACO? And the second question is, are ACO incentives self-financing? And I'm going to tell you in just a minute, and actually beginning the next slide, why these are the important questions to ask and what the answers are that we come up with in simulating our model. So questions for the model. What is the optimal size for an ACO? ACOs have to have at least 5,000 patients in them. You might ask yourself why that is. Here's why. Efficient incentives reward good actions, not good luck. But performance measures are determined both by good actions and good luck. Did your patients get leukemia? Well, all of a sudden you've blown out your cost targets, right? Or are your patients unusually complicated or unusually non-compliant? Well, all of a sudden you've blown past your quality targets. So there's luck, and there's good actions, and there's good luck. The solution to parsing out the effect of good actions and good lucks on performance measures is to average outcomes across many patients and many providers. That's the standard practice in healthcare, and it's a very sensible practice, but it comes at a cost. Pooling across many providers creates a free riding problem. And raise your hand if you've heard the word free riding problem. Now, those of you who haven't lived with teenagers long enough. What a free riding problem says is that when you got benefits that accrue to a group, the incentives for individuals to engage in those actions diminish the larger the group. So if I'm a physician with 2 people in it, I control half of the cost and quality measure, two physicians. I control half of the cost and quality measures in the group, and so I have a lot of control over what the group-based measures of cost and quality are going to be. If there's 10 of us, I only control 10%, right? And so I get to, if other people work hard and make the group cost-effective and efficient, I get to live off of those. I can slack off, and the group's not going to be hurt very much. That's a free riding problem. And it basically says group incentives get weaker, get diluted as the size of the group grows. Remember, the size of the group we're talking about here, those ACOs I showed you, had hundreds of physicians in them. Okay. So is there an optimal ACO size that balances the costs from free riding, that people can free ride off of the efforts of others in the groups, with the gains from reducing the role of luck in your performance measures? Is there a sweet spot? And then the second question is, can ACO incentives be self-financing? And by that I mean, can ACO incentives generate sufficient savings to finance bonuses large enough to generate the savings in the first place? I'm going to take you in a minute. That's a mouthful, but I'll take you through what that means in just a minute. So, answer to question 1, optimal ACO size. There is no optimal ACO size, it turns out. From an incentive perspective, bigger is always worse. As ACO size increases, the bonus required to achieve any given cost and quality target increases. There is no sense in which pooling and reducing the role of luck actually makes your incentives more efficient or more effective. There are many other advantages of size that I'll consider in just a minute. For the economists in the room, just a note, this result does not depend on the values we assign to unobserved model parameters. It's a deeper theoretical. It depends on more general relationships that you'll all be happy about. Question number 2, are ACO incentives self-financing? Suppose the payer wants to achieve modest cost reductions with no degradation in quality. Will the savings be enough to generate the requisite incentive payouts? In other words, will you save enough money to pay people enough to induce the behaviors that generate those savings? The answer to this question depends on how important random chance is in moving cost and quality measures, And we actually estimate that using data from a million chronically ill patients of a very large insurance company. So we use cost and quality data on a million chronically ill patients provided by a large insurer to estimate how much of the variation in cost and quality measures are due to random factors outside the physician's control. We plug that into our model, and we get surprising results. And here are the results. ACO's incentives are not self-financing. Here's what we mean by that. Imagine how much costs would fall if there were no free riding and docs kept 100% of cost savings. In other words, the most powerful incentives you could possibly design. Now suppose that the payer wants the ACO to achieve 20% of this maximum savings from having good incentives with no change in quality. Let's assume that's the goal of the payer. If these, what are called first best incentives, yielding savings, say, of 30% of costs, this means the target of the payer would be, we're going to target a 6% cost reduction, right? Not enormous, but very, meaningful. How large would the bonus share have to be to achieve this modest cost savings for ACOs? How big would how much of the savings would you have to share with the physicians in order to achieve this goal? The results are plotted here. And if you look, I don't know if you could see that. Can you see this in the back? Probably not. There's the size of the team in terms of the number of physicians in our simulated model. And here is B, the fraction of savings that are shared with the physicians. And this is to achieve the 20% of first best incentives cost reduction targets with no degradation in quality. And it turns out that if you have a team size larger than 5 physicians, you're going to need a bonus that's more than 100% of the savings. If you go down to 20, you're going to need a bonus about 400% of the savings, right? And what that tells you is these things are not self-financing, right? The organization is going to have to be operating with underpowered incentives, with incentives that are not strong enough to achieve the targets. Now, you might quibble with this. So let's look at the same question a different way. Free riding, as I've already pointed out, undermines incentives as ACOs get big. By the way, the problem gets impossible at size 5 in our simulation. You saw those ACOs had hundreds of physicians in them, right? It becomes a completely unmanageable problem at that size. But perhaps the problem is that payers are choosing overly ambitious cost targets. Perhaps 20% of first best cost reductions is just way too ambitious. So would more modest targets lead to self-financing incentives? And here we have an answer to that question. Here we got target savings as a percent of the first best. And here are the maximum team size that's self-financing. So let's say you were really, really, really modest in your goals, and you only wanted to achieve 5% of what you could of the cost savings you could achieve on the first best incentives. So you're talking about maybe a 1% or 2% improvement in costs. If you get a group size above 16, it's not self-financing anymore, right? So the problem doesn't go away if you choose more modest goals. The problem is there's something about group incentives in large groups that deteriorate very fast. And we're talking about groups that are clearly of a size where these things are not self-financing. So what about efficiency gains from size? We're used to thinking about big things being more efficient. There are returns to scale. You could do stuff. You could specialize. You could bring in all kinds of new technology and spread it across a large base of patients, right? Maybe that's what's missing from our story. That if we just acknowledged how much more efficient these ACOs will be because of their size, this incentive problem goes away. Well, it turns out it does not. Big ACOs may be more efficient than small, fragmented organizations. Scale enables specialized processes and investments in technology. So if they get very efficient, then wouldn't even a small bit of extra effort generate enough savings to make these incentives self-financing? Couldn't these efficiency gains make meaningful pay-for-performance self-financing even for very large groups? In other words, if they're just really efficient, these big groups, even if you get a little bit of a kick from the docs, that's going to be enough to generate enough savings. The answer is, our model says probably not. If you look here, this is the team size, again, and this is the how much more efficient the big group would have to be than a small group in order to make the savings self-financing. So if you look at a group of 20, you'd have to be 400% more efficient. You'd have to get an efficiency gain of 400% to make these self-financing. That seems off the charts optimistic. So what's the takeaway? If ACOs have underpowered pay-for-performance incentives, how can they succeed? And the answer is successful ACOs must rely on complementary incentive strategies. They're not just a bunch of people connected by a common pay-for-performance system. Some other motivator has to be going on inside ACOs for them to work. And we know what those other motivators are because we've studied them in lots of other organizations. We, by me, people like me who study the insides of organizations. There are deferred compensation and performance bonds, where if you do a good job now, in 5 years you get paid a big sum of money, right? That's a way to dramatically amp up incentive intensity. Another way to do it is to reduce the opportunity cost of effort by narrowly defining jobs. In other words, if you're my employee and you're a surgeon and I want you to come to a process improvement meeting, I tell you to come and you have to come, right? There's nothing else you could do with your time. You're not going to be seeing patients. But if you're an independent contractor working with these hybrid ACOs and I tell you to come to a process improvement meeting and you say, well, maybe I'll come, but I'm giving up an operating room where I'm making $5,000 for the next hour. Are you going to pay me $5,000 to come to this process improvement meeting? I think not. I'm not going to show up at the meeting. So when you employ a physician, and you could restrict what else they can do with their time because you're their employer, all of a sudden, small incentives can be very powerful. We've known this for a long time about this is how big organizations actually function. So these two strategies, they're mutually reinforcing, and they're used all the time by truly integrated organizations in healthcare and outside. Other strategies are important too. Peer pressure, mutual monitoring, socialization, all these are the kind of things that big organizations do all the time. Your university doesn't give you pay for performance to come to a faculty meeting, right? They have all kinds of other motivators to get you, Jay's laughing, but people do go to faculty meetings, and you have all kinds of other motivators to get you to go. Pay for performance isn't one of them. I'm not paid $150 by my dean to sit through my dean talking to the faculty. Okay. So truly integrated organizations rely on these complementary strategies routinely. They rely on deferred compensation, they rely on job design and authority from the inherent in employment relationships to motivate people to do things when the monetary incentives are too weak. The big unanswered question is whether these strategies will work in loosely connected hybrid ACOs of the sort of the 3 of the 4 that I showed you up at the beginning. In a world where ACOs are designed to break a coordination problem and to force integrated care into a fragmented region, that's going to happen because the hybrid ACOs that are forming in that region figure out how to make these complementary employment strategies, incentive strategies work. So the big unanswered question is whether these strategies work in the loosely connected hybrid ACOs comprised of physicians who operate as owners of small practices. If not, the effects of ACOs may be limited to settings where care is already largely integrated. Or in other words, it's a good idea, but the policy won't have the jumpstart effect that we'd like it to have in order to improve the efficiency of the healthcare system. There are lots of limitations to our work. I won't bore you with them. Let me go to my conclusions. ACOs will likely operate with underpowered pay-for-performance incentives. It's unlikely that in groups of the requisite size, it's likely the incentives will be so diluted as to be essentially meaningless from the perspective of individual physicians. Successful ACOs, therefore, will have to implement subtle complementary motivation strategies. Those might involve deferred compensation, those might involve authority and job design, those might involve peer pressure, socialization, mutual monitoring, the sorts of things we're all familiar with from our regular workplaces. It is not obvious that managers of hybrid organizations will be able to implement these complementary motivators. It's not obvious that they will have the authority or the institutional structures to implement that. Economists, health services researchers, management theorists, and policymakers have to start paying attention to this issue. In my view, it answers, Jay earlier today talked about that there's been some recent experiments with large providers, group health providers with pay-for-performance incentives, and the results were very mixed. Some providers seemed to respond to those incentives by reducing costs quite a bit. Others weren't able to do much, and the net result is just sort of noisy. My hypothesis, based on this simulation and other work, is that a lot of the variation we're observing has to do with these subtle motivators and the variations of those things across organizations. That's all I got to say. Thank you for your time.
Hi, I'm Elena Marks, and I'm with the Baker Institute, but I also chair the board of a nonprofit HMO. And ever since the word ACO came out, I kept saying, well, that's what we are. And we have, and not just mine, but the HMOs around the country have a long history of working with provider incentives because we are capitated. And I'm wondering how you think that fits in with what the ACOs are going to do, and if there are learnings that can go in both directions from the experience that HMOs have had.
I think so. And it's kind of a complicated set of lessons. In some sense, what ACOs are trying to do is what the HMO revolution failed to do, right? Which is introduce cost conscious and cost effectiveness across an organization responsible for managing a population of patients, rather. And so I think that's in that sense they're very complementary. I mean, they're trying to do the same things. ACOs have some instruments that HMOs had with them that aren't available to ACOs. Like you could put people in HMOs in very narrow networks. Can't really do that with an ACO. ACOs have other advantages. I mean, part of their mission is to establish contracts both with Medicare, a big payer, and also private payers sort of at the same times. And that coordination across public-private is not something HMOs, for the most part, are trying to do. I mean, Medicare Advantage being the exception.
So I'm Tom Feely from MD Anderson. Thank you again. This was a great overview of the problem. So, as you've heard, MD Anderson is not an ACO, but we do work in integrated practice units, as Dr. Mendelsohn explained. And I'm interested in hearing more about your complementary motivational strategies, because John is a very charismatic leader, and he actually said, look, we need to take 20% out of our cost structure over the next 5 years, had teams working on this. And I have to say that despite him sort of wanting that to happen, it didn't happen. And we have all highly motivated physicians. They're not on fee-for-service. While we're paid by fee-for-service, they're all self-employed. What motivational strategies do you suggest? Because we're kind of in a locked-in place, right. And we know we have to take cost out of the system.
I don't know. I don't have an answer to that question. And it's actually an area of active research of mine. One of the things I'm beginning to do with some colleagues in Boston is looking at how hospitals in the Boston area are trying to transform their cancer delivery in response to pressures from ACOs. So there isn't a magic bullet. I don't know of a magic bullet. the things I mentioned are things that in the theoretical literature and the empirical literature about how incentives work inside organizations outside of healthcare, these are the things that come up. You know, in the healthcare world, there's a tendency to think that if we simply get incentives right, if we simply establish sort of enough monetary incentives, everything else kind of takes care of itself. But I think that's based on an idea of sort of individual piece rates. It's not looking at how the insides of organizations actually function. And the insides of organizations are actually environments where they're specifically, you know, this goes to a really fundamental issue in economics, which is why are there some things done inside, about half of economic activity happens inside of organizations, not markets. Why is that? What is it about some kinds of activities that happen really well inside organizations and others that happen really well inside markets? And the things, the growing consensus is that the things that happen inside organizations are things where close coordination really matters a lot, and high-powered financial incentives create too many distortions. In other words, the inside of an organization is a place where you design things to get people to work closely together with actually a minimal amount of financial pay for performance. So how do you do that? One way you do that is by manipulating the opportunity cost of individuals' time. So you say to people, look, like the example of process improvement meeting is kind of perfect. You can't see patients. Your job is not to see patients during the time of process improvement. And if you don't like that, it's my authority. It's within my authority as an employer to specify what your job scope is. If you don't like that, you can get another job. But you're not having to battle the person being drawn to their independent practice or something. So that gives you an enormous amount of control. Let me give you an example of that from my own teaching. What classrooms do, you know, how am I able to control 100 rowdy MBAs who, with you know, nothing but a grade in a class they'll never care about again to control them? Well, part of the way I'm able to do it is we put them in a classroom where the opportunity cost of their time is about zero, right? If they're not paying attention to me, there's really nothing else to do, right? So it becomes very easy with very low power incentives for me to get their attention. Now you bring in laptops and the whole internet into the classroom, and it becomes, all of a sudden the opportunity cost of their time goes up. It's much harder to get their attention. Well, you have that same issue inside organizations. A big piece of that has to do with the sociological idea about the legitimacy, right? If I tell a physician he can't do something else, or she can't do something else, she's got to attend this process improvement meeting. That works a lot better if what I'm asking them to do is plausibly part of what they see their mission as, right? Which is treating patients better, maybe treating patients without wasting resources, right? If you just try to force people, that's a recipe for a lot of resentment, right? And a lot of non-cooperation. So organizations that try to manipulate people's actions by reducing the opportunity cost of their time also put enormous amount of effort in defending and justifying the legitimacy of what they're asking people to do. They sort of do both things at the same time. So having a charismatic leader who's very good at making the case that what we're asking you to do is legitimately within a mission we all share, that's a very powerful asset, right? That doesn't appear in most economic models, but it's real. It's a long-winded answer.
Okay, that is a perfect segue into the question I have right here. In thinking about these affiliate organizations who do not work for the IPA or whoever the central insuring company is, how do you get them aligned? And what kind of incentives do you see working to provide that alignment? Because wasn't that one of the failures of the group HMOs back in the 80s? There was not that alignment. They just took contracts willy-nilly, whereas the staff model HMOs largely worked in coordinating care, not so much holding down costs.
Right.
So I don't see where these affiliate agreements with all these other providers are going to change or are going to rectify the problem that we're trying to solve.
I'm with you. If you go back to, where are we? We'll go back. The problem with animation is it's slow to go back. But if we go back to those ACOs I mentioned in the beginning, If we go back to those, most of those I'm really worried about, right? Because I don't see how, I need a story about how Monarch with a loose independent practice association with 40 employee docs and 20, how are they going to motivate these guys? Are they going to have to pay them for their time, for the opportunity cost of their time to get them to come to meetings? Well, that's going to be really tough. You can be sure that there aren't payments in the system big enough for that. This is what I worry about, and this is where I worry that it's at this margin of these sort of hybrid or virtual organizations that don't have access. They haven't socialized their physicians. They don't have established a lot of legitimacy with them. They don't have a lot of control over the opportunity cost of their time. I worry that those guys will not have the levers to elicit. And they certainly won't have the financial, if my analysis is even half right, they won't have anything close to the financial levers to change people's behaviors. So I'm with you. That's the piece, that's what I worry about with this model. I don't know, Fiona's not here, but this is where, it would be great, in some sense it would be a great idea if there was a lot more vertical integration, if they actually tried to make these things truly vertically integrated organizations as opposed to virtual organizations. It's going to be very hard to do though, because you have a whole medical profession that's selected into these onesies and twosies practices for good reasons. They're entrepreneurial, they're hardworking, they like to control their time, they like to make the money, right? And they're willing to put in a ton of hours. It's going to be very hard to get those guys to work inside an integrated organization. And if you just buy them out in name, you'll get the disasters that happened in the 90s, where they bought all these hospitals bought all these practices and nothing changed. Yeah.
Just a historical note on this. So I'm in the managed care industry, and
You're in what? You're
managed care.
Yeah.
So HMO. So in 78, 79, our mantra was control the network.
Yeah.
Control the network.
Yeah.
It didn't have to do with incentives. It didn't have to do with leaning on people to do higher quality care. Just get high quality people, and that's all you needed. That's because we didn't have any out-of-network benefits, and there wasn't any pressure on us by the NCQA, which didn't exist yet, to have access. That is, a certain number of providers per population standard. So we could pick our hospitals and pick our docs and pick our aftercare situations, and in doing so, cut costs 50, 60, 70%.
Because you could pick deficient providers, or because you had lots of influence over the providers who were in your network?
We didn't even, our influence on them was to ask them, teach us how it is that you do that so well, so fast. Mm-hmm. So it wasn't an idea that we were picking people who we wanted to teach. We were picking people who could teach us. Mm-hmm. And that all went away because our salespeople said, you're going to have open access. You're going to have out-of-network benefits, and boom. It was all gone by 1991.
Right. Yeah, I think that makes a lot of sense to me. That's a feature of the AC of accountable care organizations that I worry about as well. These are very open networks and very porous, and I do worry. There's two benefits of having control over the networks. One is you said this wasn't important for you, but I can imagine situations where it is important. You can bring in docs that you think are very efficient. Another advantage of having narrow networks is you can bring in, you could bring in physicians who are sort of highly dependent upon you for their patient population, which gives you a lot of then influence over their behaviors. I worry that with ACOs, both of those things are going to be more difficult than under HMOs.
Just one other thing we did is we paid slightly above standard rates.
Well, this is the other complementary motivator that I alluded to, which is in the labor economics literature sometimes called an efficiency wage strategy. But you could think of it about your babysitter. If you want a really good babysitter, you probably want to pay above a market rate, partly because you get better people and partly because they don't want to lose the job. The relationship becomes valuable. And again, for that to work, for that kind of deferred compensation, value of the relationship type motivator to work, you need to have you have to have long-term persistent relationships that people are anticipating are going to last for a long time into the future. And again, that's something that's easier to implement in a conventional integrated organization than in these hybrid structures, I think.
My name is Cedric Dark. I'm one of the physicians with Baylor College of Medicine, and I had a question. You had raised a point about physicians being or caring about reducing resource use, and I was a little bit opposed to that assumption because I feel as a physician we're not really taught that in medical school, not necessarily taught that in residency. We're taught to take care of our patients at almost all cost within reason. And I wonder how that assumption sort of plays into your modeling.
Into our model basically allows for physicians to be both intrinsically motivated and extrinsically motivated, right? And the intrinsic motivations we allow for are they want to do the right thing in terms of the quality of their patients, but they also don't want to waste resources in treating them. You could drop that second assumption if you want, and nothing would change in our model because all the action happens beyond a certain point. Even if people are intrinsically motivated, beyond a certain point, you need to pay them to do a little bit more, and that's where our model is actually operating. So in terms of the technicalities of the model, nothing hinges on the assumption that people care about both cost and quality. In terms of your training, though, I do believe medical schools are making an enormous epochal mistake by not teaching their physicians to think about how to innovate both in terms of quality of care and efficiency of resource utilization. It would be a very good thing if they taught physicians how to innovate along both dimensions.
Carla Braxton from Baylor Surgery and the VA Medical Center. I missed part of your talk because I got paged out. Sorry.
It's all right.
But I wanted to know if you had addressed this at all. Can accountable care organizations coexist with private physician practices and that physician autonomy that's so valued here in Texas in particular? There's a lot of discussion now among Texas physicians within the TMA and so on about the shrinking of private practices and small group practices and rural practices and so on, as much as there's a need for physicians who are willing to practice in areas that have a lot of disparity, et cetera, et cetera. I mean, how can they coexist, these accountable care organizations, kind of large, groups of physicians and practices and hospitals and so on all together, plus the private doctors that really value their independence and their autonomy?
The battle over the independence or autonomy of the medical profession goes back generations, right? And you could there's a famous whole set of laws from the early part of the 20th century called the Corporate Practice of Medicine laws that were simply implemented to prevent physicians from becoming degraded in the same way as lower orders of professionals like engineers were, and subsumed under larger, potentially more efficient but very powerful organizations. So this battle about the autonomy of physicians as a learned profession is a theme that goes way back. It's not just a Texas theme. What's brilliant about the ACOs is they're an attempt to try to create kind of transitional organizational forms that will hopefully, at least in the perspective of their advocates, collapse eventually into truly integrated organizations, and we can get rid of some of this autonomy. But they're designed to enable small group practices to participate, like Monarch here, to participate in larger integrated entities. But the problem is it's based on a notion of what integration is that says an integrated organization is a bunch of providers connected by a common incentive system. And I hope that I've persuaded you that that's an inadequate view of what organizations do. and what gives whatever efficiency advantages there are to integrated organizations. They're much more than individuals connected by a common incentive system. And so I think that there's this tension that the law is designed in a way to enable these transitional forms like Monarch, where you get 2,500 affiliated physicians trying to integrate with each other. I worry that it lacks, the law presumed in its design that pay-for-performance incentives at the top of a large organization would be enough to make people work together. And what our analysis suggests is clearly not enough. And these other motivators might be very difficult to do, hard to do, in the setting you describe.
Hi, I'm Laura Peterson. I'm a physician, health services researcher from Baylor College of Medicine and the Houston VA. So this was an outstanding talk, and the whole day has been wonderful. I just recently published the results of an experiment where I looked at incentives to individual physicians as well as groups, and I definitely showed what I think was a free rider problem with the group incentives.
Oh, I think I read that. That was you.
Yeah, that was me. So, so I completely agree, and this whole idea that you can incentivize this giant organization and expect individual docs like me on the front lines to change their behavior is really misguided. So thank you for bringing attention to that. My question is really about the VA. I mean, when you think about it, it's one of the most highly developed, vertically integrated ACO types of organizations that we have in this country, and it's certainly much more developed than these examples you have. It has its own peculiarities, of course, but I would really like your help in thinking through, and we could talk about it later, too, is how could we try to learn from some of what the VA has learned over the years and modeled?
Yeah, well, I don't know. My daughter works for the VA, which does not make me an expert on it. So I don't know enough about it. I know that to the extent they were ahead of the rest of the country in certain kinds of what you might call pro-integration technologies, like medical record technologies, which is kind of amazing considering how sluggish and moribund and bureaucratized the organization is in so many other dimensions. I believe that all the physicians at the VA are also employees of the VA, which are salaried, right, which creates enormous opportunities for integration, as we talked about, that are not available elsewhere. I can't underscore enough how important having a true employment relationship is in making these kinds of integrated things work. And so that gives the VA certain advantages. They have disadvantages too. You might argue that in a world of highly entrepreneurial, fragmented practice, they attract the less driven, the less extreme, the less high motivated physicians. I don't think that's so true now as it might have been a generation ago, but that might be something that you have to worry about. There's lots of things to worry about with the VA model, but those two features of it, I think, are very promising. Thank you.
Thank you, Jim. So we've reached the end of the program. I would like to thank our 6 speakers who clearly put a great deal of thought and effort into preparing their presentations and really have given us a lot of information today. And I appreciated your being patient with all of our questions, too. So thank you. I'd also like to thank our audience. Thank you for coming today. Thank you for, as usual, asking terrific questions that really helped elevate the conversation and help sort of elevate my understanding of what's going on in terms of health policy. So I hope you continue to stay with us and come back in another 2 years. Really, in these conferences, I go and sort of call up and line up the speakers and fix the date when they can all make it into Houston. And then there's this entire staff behind me that does all the work. So I would like to thank the people on the health policy staff. Brenda Laymance put a lot of work into getting things organized. Mara Short over here as well. The event staff here at the Baker Institute, and in addition, they were doing this in addition to preparing for our gala, and they've been extremely busy. So thanks to Whitney Smith and Melissa Llewellyn and David Martin, and also thanks to Kevin Young and his whole crew. You don't see them, but they're behind, doing all the audio visuals and getting the slides ready and getting everything webcast. So thank you to all of you for your help. And with that, we've got a reception, and it's outside. But it's truly outside. So it's outdoors, outside the building, and you're all welcome to join us and maybe have a chance to chat with our speakers. And look forward to having a good weekend. Thank you.